You can ask about the onset, site of pain, character, duration, radiation, any aggravating or relieving factors, any tenderness, local tenderness is or presence in musculoskeletal pain like T syndrome, any associated symptoms like nausea, vomiting, any severity. Characteristic of chest pain site is cardiac ischemic pain is generally central, may radiate to jaw, neck and left arm. Patient complains of chest heaviness, any pressure on the chest, and pulmonary chest pain or respiratory chest pain localizes to the site of pathology. Infection or pneumothorax. Our patient with asthma or COPD may complain of central chest pain or tinnitus, but other features is the subsequent history will help in differentiate is this from cardiac ischemia. Musculoskeletal chest pain localizes to the site of pathology or injury, may relate to posterior chest region of the spine. Peptic ulcer disease or gastroesophageal reflux disease generally to epigastrium or lower chest. Nature of chest pain. Cardiac ischemic chest pain is pressure-like sensation or heaviness in the chest. And respiratory and musculoskeletal pain are sharp and pleuritic. Pericarditis pain is sharp and pleuritic. Nerve root pain is band-like shooting pain around the chest from back to anterior chest. It is generally seen with the herpes zoster. Gastroesophageal reflux disease is sharp and burning sensation. And radiation chest pain, cardiac ischemic pain generally radiates to jaw, neck and arms. Aortic dissection, peptic ulcer disease and pancreatitis pain radiates to back. Now root pain forms a band around chest wall like band-like pain sensation. Then onset, duration and frequency. When did the chest pain start? Does the chest pain come on suddenly or gradually? It is constant or intermittent. If intermittent, how frequently do you experience chest pain? Precipitating like exertion. Cardiac chest pains are generally precipitated by exertion, relieved by rest. Whether whether it's precipitated by deep inspiration or not. Respiratory, musculoskeletal chest pain, pericarditis pain are precipitated by deep inspiration. And musculoskeletal pains are precipitated by movement. Gastroesophageal reflux disease pain is precipitated after meals. Whether any relation with position, pericarditis, pancreatitis, gastroesophageal reflux disease, worse by lying down or bending forward. Relieving factors is cardiac chest pain is relieved by rest, or sublingual nitrates relieves chest ischemic chest pain, esophageal spasm. Antacid relieves peptic ulcer disease pain, gastroesophageal reflux. Simple analgesics relieves musculoskeletal pain, and bronchodilator relieves asthma or COPD pain. Associated features, cardiac ischemic chest pain have nausea, vomiting, sweating, pallor, breathlessness, maybe manifestations of ischemia. Respiratory tract infection have cough, productive or non-productive sputum, fever, hemoptysis. Pulmonary embolism has non-productive cough, hemoptysis, calf pain, history of immobilization, history of trauma, any swelling in the calf, and lung malignancy have productive cough, hemoptysis. Pericarditis have like cold, flu-like symptoms. Peptic ulcer disease have nausea, vomiting, hemoptysis, and melena sometimes. Gastroesophageal reflux disease, which is called GERD, also has acid taste in mouth, dysphagia. Musculoskeletal has back pain, joint pains, nerve root pain, like it's seen in shingles. Inquire about the history of any chest trauma. Past medical history is also very important, like in cardiovascular chest pain, past medical history of smoking, hypertension, diabetes, family history of MI, previous history of myocardial infection. Thrombotic risk factors like previous history of thromboembolic disease, thrombophilia, malignancy, immobility. Peptic ulcer disease requires ask patient about any previous history of endoscopy. And pneumothorax, recurrence of pneumothorax is common, and up to 15% of recurrences can be seen on contralateral side. Medications inquiry about any drug history, patient already any drug for this cardiovascular disease, any compliance to therapy, Then social issues like smoking habits, which is #1 risk factor for cardiovascular risk factor. Alcohol consumption, inquire about the job history, heavy lifting, manual labor may contribute to musculoskeletal pain. Ischemic versus non-ischemic chest pain. Like ischemic chest pains are central and diffuse, whereas non-cardiac chest pain peripheral localized. Ischemic pains radiate to jaw, neck, shoulder. They are tight, squeezing, choking in character, precipitated by exertion or emotions, relieved by rest or nitrates, associated with breathlessness. There is no such history in non-cardiac chest pain. Chest pain due to ischemic heart disease may manifest as angina pectoris, relieved by rest, not associated with vomiting. Myocardial infarction, not relieved by rest, associated with vomiting. You can see here the normal artery and the blocked artery. Plaque is seen there. Characteristic of cardiac pain. The pain of MI typically takes several minutes or even longer to develop. Similarly, angina builds up gradually in proportion to intensity of exertion. The pain of aortic dissection, massive pulmonary embolism or pneumothorax is usually very sudden and interstitial onset. Cardiac pain is typically located in the center of the chest because of denervation of the nerve supply to the heart and medium. Radiation, ischemic cardiac pain may radiate to neck, jaw, and upper or even lower arms. Occasionally, cardiac pain may be precipitated only at sites of radiation or in the back. They typically use characters for cardiac chest pain like open hand or clenched fist with when describing ischemic pain. It is called Levine sign also. You can see the patient showing the Levine sign, like heaviness in the chest or pressure over the chest. Anginal pain occurs during exertion and promptly relieved by less. The pain may also be precipitated by emotion but tends to occur more relieved during exertion after a large meal or in a cold weather. These are some risk factors for development of ischemic heart disease like male gender, increasing age, hypercholesterolemia, hypertension, cigarette smoking, diabetes mellitus, obesity, sedentary lifestyle, and genetic factors. These are some of the life-threatening causes of pain like acute MI or acute coronary syndrome, pulmonary embolism, acute aortic dissection, and tension pneumothorax. But there are so many causes of chest pain from benign to life-threatening, but we have to be more careful about life-threatening chest pain. We can assess patients by any like character of pain, any past medical history, and examination, vital signs, ECG, X-ray. The take-home message is that we should not ignore the life-threatening chest pain. We must assess this properly. Thank you, sir. Hello.
Thank you for excellent presentation. So, whenever patient come to us in a cardiac emergency, we generally classified the patient into two groups. One patient with a cardiac chest pain, another patient with non-cardiac chest pain. So, cardiac chest pain, usually patient present with the central chest pain that radiate into the left arm